In today's topic of discussion of maternal Tdap immunization, we are trying to find an answer to a single question. That is present day practice, is Tdap immunization is indicated in maternal immunization? Many times obstetricians do ask the pediatrician's opinion regarding this. We all know that there's no national program in India, but private immunization, is it indicated? Because the immunization, the vaccine is very well available. And many times I find the pediatricians are a little confused about. We will be discussing this under the following headings: background information and introduction to the antenatal vaccination, effectiveness of antenatal Tdap, safety of Tdap, and the blunting of infantile immunization by maternal Tdap. This is, many pediatricians are concerned that if there is a lot of antibodies crossing the placenta and a very high antibody titer in early newborn period as well as in infancy might affect the effectiveness of the immunization in childhood immunization. This is a topic which I will, there is some confusion and I'll try to throw some light onto that particular matter particularly. Now we'll finally end up with the international national recommendations so that there's no ambiguity on this matter. Let's begin with some introductory remarks and background information. Introductory remarks. Now, Tdap contains tetanus toxoid, which is the equal, it is the potency is same as that given for childhood and adult vaccination. D is in small letters because it is reduced diphtheria toxoid, and AP is acellular pertussis vaccine, not the whole cell vaccine. Now, our main concern about Tdap is regarding pertussis. A discussion in this, though we are discussing Tdap, we'll be mainly discussing pertussis component because tetanus is well entrenched into maternal immunization and nobody needs to, I don't have to explain anything. And diphtheria is mainly given so that the weaning immunization weaning immunity gets a booster. Now, why the pertussis on the rise and outbreaks are happening globally, even in Western countries like America and developed countries like America and UK. The Center for Disease Control reported 307 deaths from pertussis from 2000 to 2017. Children younger than 2 months amounted for 84% of these deaths. In fact, pertussis is the most common vaccine preventable disease occurring even in the West. Therefore, a vaccine preventable disease death is one case itself is too much as far as Western countries are concerned, and even all over the world, this is very, very significant. Most of these deaths are among infants who are too young to be protected by childhood pertussis vaccine series, which starts when the child is 2 months old in Western countries and 6 weeks in developing countries. In India, we give the doses 6, 10, and 14 weeks. And after the primary doses, it takes at least 2 weeks before the immunization starts kicking in. And for complete protection, it may take few more weeks. Therefore, to help protect the babies during this time, that is newborn and very early infancy, when they are most vulnerable, women should get Tdap, and that too during each pregnancy. To each pregnancy, they should get a vaccine. Now, maternal vaccine has the potential to provide clinically significant protection for the mother and infants. It protects the mother and infants. But however, primary aim, especially in pertussis, is the prevention of pertussis in young infants who have disproportionately high burden of severe pertussis. Now, it's important to prevent in the mother because 50% of the neonatal infections do occur, the source of infection, the mother herself. The immunization delivery system globally and even in US is traditionally focused on childhood vaccines. Maternal vaccines has been ignored. Maternal vaccines against pertussis are not recommended in the developing world due to unclear burden estimates and possible infant vaccine response attenuation by maternal antibodies. We will come to this much better because even pediatricians have a feeling, I mean, rightfully so to a certain extent, that if you give vaccination to the mother and there are high antibodies in the immediate neonatal period, your vaccine which you give at 6, 10, and 14 weeks may not be that effective. the antibodies present already in the infant may interfere with the efficacy of the infantile vaccination for some valid reasons. Now, the vaccination of women in pregnancy is believed to protect infants in pertussis in two ways. One, first, is likely to increase the transfer of maternal pertussis antibodies through the placenta and through the breast milk. Second, vaccination during pregnancy is likely to prevent maternal infection at the time of delivery, which in turn minimizes the infant's potential exposure to pertussis. In fact, they say more than 50% of the neonatal and early infant infection in infants come from the mother. The mother is the source of infection. Therefore, when you give immunization, especially Tdap, which contains pertussis, diphtheria, and tetanus, it protects the mother and as well as the child in turn. Studies suggest that one of the main reasons for low immunization rate is clinicians or women's concerns about the safety of the vaccine during pregnancy. In fact, I found that many times when the obstetricians ask the pediatrician opinion about the safety during pregnancy, a definite answer is not given by the pediatrician also. The precautionary principle-centered approach combined with the risk aversion among legal departments of vaccine manufacturers led to exclusion of pregnant women and most vaccine trials for decades, leading to gaps in evidence of vaccine safety and efficacy among pregnant women. Now we know that even in COVID, though the COVID was more severe in pregnant women, and it also affected the infants, newborn babies, it could affect very severely. Vaccination was not advised because there were no trials done. This is because of the precautionary principle-centered approach, because vaccination as well as medications are considered dangerous in antenatal period. Of course, there's a definite change. Now the whole of the United States of America and the South America and some countries in the Gulf, if you look at even Oman and Australia and New Zealand, are giving have maternal vaccination routinely in the antenatal period in the national programs. At least 40 countries, according to an article in 2020 in the expert review of vaccines, at least 40 countries are currently recommending maternal immunization as part of their routine immunization schedule, including the United States and the United Kingdom. These two countries are advising from 2012 onwards. That means for the last 10 years. If you look at the Indian scenario, the primary immunization, the national program in government hospitals is given by the wholesale vaccine at 6, 10, and 14 weeks, and is followed by booster 16 to 24 months and 4 to 5 years of age. The Indian Academy of Pediatrics does advise AP vaccine, and most of the private people give acellular pertussis vaccine. There is no national policy of booster immunization of pregnant women or any specific age group beyond 5 years of age. Limited usage of acellular pertussis vaccine at 10 years and during pregnancy exists in the private sector. The WP wholesale vaccine is not offered to older children than 7 years and adults, including pregnant women, due to the risk of adverse effects. The next point of discussion is the effectiveness of maternal Tdap. As I already said, the effectiveness of tetanus toxoid is well known, and we are mainly going to concentrate on acellular pertussis vaccine. In UK, the maternal Tdap vaccination was implemented in 2012, nearly 10 years ago, during an epidemic of an infant pertussis. As it often happens, during an epidemic, there's often a knee-jerk reaction all over the world. Overall, 91% effectiveness in protection against pertussis in infants during the first 3 months of life was observed after the introduction of maternal Tdap, when administered at least 1 week before delivery. After the maternal immunization program in England was put in effect, the Joint Committee of Vaccination and Immunization noted for the first time after 1993, no infant deaths were reported in 2017. Therefore, in 2017, there were no infant deaths due to pertussis, and that the rates of disease in young infants was lowest since 1998. Year after year, the incidence, hospitalization, and death of pertussis decreased in infants. Maternal Tdap vaccination was also known to reduce the number of hospital admissions. Now I picked up one country just like that where the statistics is well available. Most of the data on the effectiveness and safety of maternal pertussis vaccination comes from observational studies, and some pediatricians and obstetricians point this as a negative point of giving Tdap vaccine. But the recommendation to administer Tdap vaccine to pregnant women evolved in response to large national and subnational pertussis outbreaks in 2012 in UK, where they were found to be highly effective, which we have seen already. The genesis of these recommendations is erected ethical barriers to the conduct of phase 3 trials or Tdap vaccination in countries that recommend maternal pertussis vaccination. Because for phase 3 trial you require control, and for the control you have to deny, you cannot give the Tdap vaccination. Therefore they consider it unethical to deny mothers in the control group Tdap vaccination, which is already proved to be highly effective. Now the WHO, now there might be some doubts. WHO even in 2015 has made a statement. Recent evidence consistently indicates that maternal immunization with AP containing vaccine during the third trimester of pregnancy is safe and highly effective in protecting infants. Therefore, this is WHO standard from pertussis, and that may have a high impact on morbidity and mortality in infants too young to be vaccinated. WHO organization in 2015 concluded that maternal immunization was likely to be cost-effective additional benefit strategy to protect young infants from disease. This is because almost half the deaths in children under 5 years of age occur during the neonatal period, and infections account for 22% of them. And the 10 to 15% of stillbirths are attributed to maternal infection. Therefore, if you want to decrease childhood mortality, infant mortality, neonatal mortality has to be brought down. If neonatal mortality has to be brought down, neonatal infections have to be brought down, and which account for nearly 50% of the 22% of the childhood mortality. And also, if you want to bring down stillbirth also, the maternal infection has to be brought down. For all these cases, maternal immunization, not only Tdap, but other immunizations like flu vaccines, respiratory syncytial virus, etc., are being promoted by WHO. Now coming to the safety of the maternal Tdap. The existing evidence has not demonstrated that having a maternal pertussis vaccination during pregnancy is associated with an increased risk of any serious maternal or perinatal complication, such as hypertensive disorder, stillbirth, neonatal death, or preterm birth. There's no significant complication. But a large study conducted in a network of US-based managed care organization showed no increase in adverse birth or pregnancy outcome, with the exception of a 20% higher adjusted rate of chorioamnitis diagnosis among women who received Tdap vaccine during pregnancy. There was a slight increase in chorioamnitis was reported. Notably in this study, there was no increase in the risk of preterm birth, which was the main clinical outcome of concern associated with chorioamnitis. But at the same time, in another study in USA, there was no increase in risk associated with concomitant administration of influenza and Tdap vaccine during pregnancy. Now, even this chorioamnitis, there is a doubt, because in the United States of America, because of legal problems, most of the patients who develop a fever after vaccination are immediately diagnosed as chorioamnitis. This could be the reason. This is given even in international journals. Why I'm telling this is because some obstetricians or pediatricians may point out that there is a higher incidence of chorioamnitis in patients who are vaccinated with Tdap vaccine. And the background information I have already given. Now, what are the most important things which is often discussed, which we have to discuss in some detail, is a blunting of infantile vaccination by maternal Tdap. Maternal antibodies may interfere with the infant response to routine immunization with Tdap, with the diphtheria, tetanus, acellular, pertussis vaccines in the infancy, raising concerns of suboptimal protection after infant vaccination. This can occur after whole cell vaccine also. The immunological interference is called blunting. Therefore, this is something of concern. We don't want the infant, because of Tdap, the infantile immunization, childhood immunization should not get affected. The blunting has been observed for maternal antibodies acquired after natural infection, but also for maternal antibodies induced after vaccination. The blunting effect on pertussis response disappeared in a number of studies after booster vaccination. Therefore, this may not be of much importance because after booster, the blunting effect disappeared. Post-booster blunting persisted in 5 studies, including the large RCT from Canada, which has the most robust post-booster data to date, with a total of 239 samples of infant sera assessed at the booster dose. Therefore, not only some of the studies, and probably one of the very important studies from Canada, the post-booster also the blunting persisted. That means when you give the infant immunization, the antibody response was not that good. Blunting of diphtheria response was also seen in primary vaccination in some studies for diphtheria also. The previous one was regarding pertussis, while the effect on tetanus response was inconsistent between studies. For childhood diseases with well-established correlates of protection, there is no clinical relevance of the infant's blunted immune response, since most infants reach seropositive level after primary or booster vaccination series. Now in diphtheria and tetanus, there are childhood vaccines with well-established correlates of protection, and after the booster, the seropositive levels were good. Therefore, there is no clinical relevance. It is only in pertussis that even after booster, some studies show that it doesn't. It's not this. It has a significant difference from children, from mothers who have not received Tdap vaccination. Now, is there a greater attenuation with DTW vaccine? There's another thing. What it means is, some people have said that this interference is more when the child is vaccinated with whole cell vaccine. Studies evaluating the attenuation in infant DPT response by infection-derived maternal bodies have had heterogeneous findings. Overall, however, there was greater attenuation in immunogenicity in those who received DTP vaccine containing whole cell vaccine than in those who received acellular vaccine. This is a New England Journal review article in 2017. There are emerging data on the effect of vaccine-induced maternal pertussis antibody on DTAP vaccine, whereas apparently no studies have assessed such response in infants receiving DTWP vaccines. This is in 2017 review article by New England Journal. This is quoted by many pediatricians also as a point against giving Tdap. Now the WHO posting paper in 2015 also gives credence to this thinking. The evidence review relates only to the use of AP containing vaccine in pregnancy, and the immunogenicity data confined to infants vaccinated with AP containing vaccines. Conclusions on maternal immunization therefore cannot be extrapolated to infants receiving whole cell vaccine in the absence of additional immunogenicity studies and safety data. This is 2015 WHO. The value of this strategy will need to be further assessed in women who have been primed with AP vaccine in childhood, and also evaluated in low and middle income countries where early accelerated schedules of whole cell vaccine combination are in place. Supporting what the WHO says, a study done much later in 2020 reported an association between pre-existing maternal antibody concentration and the blunting of immune response to pertussis toxin after whole cell pertussis vaccination, but not after acellular pertussis vaccination. But this has been contradicted in an earlier studies in 2018 in the reputed Journal of Vaccine. Maternal pertussis antibodies did not attenuate infants' immune response to pertussis antigens in whole cell primary vaccine given at 6, 10, and 14 weeks of age. We found no association between higher pertussis antibody titers and post-immunization 18 weeks pertussis antibody titers in infants who had received at least 2 doses of whole cell vaccine. Therefore, the results are heterogeneous. What will be the evidence regarding antibody level? The most important point to note is there is no epidemiological evidence that children whose mothers received Tdap vaccine are at increased risk of pertussis after pediatric vaccination, although longer follow-up is required. Remember, there's already 10-year follow-up in UK and USA. There is no increase in childhood pertussis in countries with universal maternal immunization program. This should be clear, and probably this is the most important statement in my presentation. Almost 40 countries are giving this immunization. Don't forget that. One interesting aspect which has come up is that whether we can delay the first dose of infant immunization up to 3 months, especially because there are maternal antibodies persisting up to that time in mothers who have been given Tdap vaccination. And there also the Western people are looking whether they can reduce the number of the childhood immunization, the number of doses of childhood immunization mothers given Tdap. This has been studied in a Dutch study and published in 2019 in the Lancet. Now, they say that together the data suggests that timely Tdap vaccination around 30 to 32 weeks leads to term babies having high pertussis concentration until the age of 3 months, which might allow for delay in the primary vaccination up to the age of 3 months. Our data support introduction of a 2+1 schedule starting at the age of 3 months, given that antibody concentration is similar between infants of this reduced schedule with maternal Tdap vaccination, and historical data of a 3+1 schedule starting at age of 2 months without maternal immunization. However, the value of the delayed and reduced schedule will depend on the coverage of Tdap vaccination in pregnancy, and the effectiveness of this schedule should be closely monitored. Therefore, in times to come, the primary vaccination, especially in Western countries in children born to who mothers have been given Tdap vaccination, may be delayed up to 3 months, and a reduced number of doses may be given. I understand Netherlands has already started doing this. Another interesting question, which is more relevant to developing countries, is the mothers who received whole cell vaccine in childhood, are the infants protected? Or do they have, generally whole cell vaccine is supposed to have a longer persistence of antibodies than acellular vaccine. This is well accepted all over the world. Therefore, some of the pediatricians in developing countries do feel that because we give whole cell vaccine, which is more effective, the mothers may still be protected and their children may also be protected. Now, for the first time, there is an Indian study in this published in archives as late as 2021. They said the protective antibody titers were observed in 72.3% babies vaccinated with Tdap during maternity, compared to 21% of newborn babies or mothers who were not vaccinated in pregnancy. Only 21% of newborns born to mothers who were not vaccinated in pregnancy had protective antibody titers. Protection is low in infants born to mothers who received whole cell vaccine in childhood compared with women immunized during pregnancy. Therefore, the idea is that your childhood vaccination with whole cell vaccine, though it is probably more effective and longer effective, the antibodies persist for a longer time. The mothers do not have enough antibody titers to protect their newborn period in the critical time. Because I want blunting the listeners to go away with a clear idea of what's the clinical importance of blunting of antibody response due to Tdap vaccination. You should be very clear after my presentation at least. Now I will summarize them in the following points before going further in this presentation. Transplacental antibodies cause interference with immune response to pertussis vaccination, if the effect of which was still apparent before boosting for the 3 pertussis antigen and after boosting for FHA and pertussis toxin. FHA is filamental hemagglutinin antigen. Therefore, this is they did persist even after boosting in some studies. Conflicting evidence regarding interference of whole cell vaccine, of there being more interference with whole cell vaccine than DTaP vaccine in infants. Whether the whole cell vaccine gets more suppressed, antibody level suppressed, there is conflicting evidence. Indian study shows that mothers who have taken DTW vaccine in primary vaccination childhood do not have adequate protection. For that alone is not enough. Therefore, Indian mothers taking all the developing countries' mothers who are taking whole cell vaccine also require Tdap vaccination. There is evidence that the delay in the first dose of 3 months and give a reduced dose of 2+1 schedule may be enough when you give mothers Tdap vaccination. This may be more relevant in developed countries. Currently, the most important point is this. Currently, there is no epidemiological evidence that children whose mothers receive Tdap are at increased risk of pertussis after pediatric vaccination, although longer follow-up is required. There is no increase in childhood pertussis in countries with universal maternal immunization program. This should be clear to everybody. Nevertheless, these findings warrant close monitoring of age-specific pertussis trends in population with maternal immunization in order to detect any shifting of the disease burden from infants who are younger than 6 months to infants who are 6 months of age or older. But remember, this is not a point of much worry for us because the morbidity and mortality following a pertussis infection in children older than 6 months who have a more mature immune system is much lower. Therefore, if at all this causes a shifting of the age group, we are not very concerned about it. The benefits of protecting newborns during the most susceptible months of life outweigh the potential risk of blunting later in life. Have a clear idea. I suppose you will, after this presentation, you'll have a clear idea regarding this. Let's look into the recommendations of the well-known international bodies like American Academy of Pediatrics, WHO, and the Indian Academy of Pediatrics. In fact, CDC talks about 5 facts about Tdap and pregnancy. The number one they say is Tdap during pregnancy provides the best protection for the mother and infant, better than cocooning. Recommend and administer or refer to your patient to receive Tdap during early pregnancy. Optimal timing is between 27 and 36-week gestation, preferably during the early part of this period, to maximize the maternal antibody response and passive antibody transfer to the infant. Therefore, if you are maybe around 27 weeks is the right time. But understand that in UK, they do it slightly earlier, 20 to 32 weeks. Fewer babies will be hospitalized for and die from pertussis when Tdap is given during pregnancy rather than during postpartum period. Straight advice from CDC. Now, what very often we see mothers who have not been taken any of the tetanus vaccine, they have to be given the full course of vaccine, 3 doses. And in this case, the 4 weeks and later 6 to 12 months may be the 3 doses. In order to provide protection against pertussis, a dose of Tdap should replace one of the TD doses. Remember now tetanus is not available, only TD is available. Ideally, the dose is given during early part of 27 to 36 weeks. Therefore, in mothers whom you don't know, incomplete or unknown immunization status, you give 3 doses and one of the doses would be the Tdap. The others will be TD. Now, some of the obstetricians are very scared about vaccinating during pregnancy and they would like to give it postnatal. Now, postpartum Tdap administration does not provide immunity to the infant who is most vulnerable to disease and serious complications. There will be no transplacental transfer and the infants remain at risk of contracting pertussis from others including sibling, grandparents and other caregivers. It takes about 2 weeks after Tdap received for the mother to have protection against pertussis, which means the mother is still at risk for catching and spreading the disease to her newborn baby during this time. Cocooning alone may not be effective and is hard to implement. The term cocooning means vaccinating anyone who comes in close contact with an infant. This was an old methodology which was followed. Cocooning is difficult and can be costly to make sure that everyone who is around the infant is vaccinated. Therefore, nowadays, maternal vaccination is preferred to cocooning. Now, what about preconception? Tdap should not be offered as a part of routine preconception care. Protection from pertussis vaccine does not last as long as the vaccine experts would like to. So Tdap is recommended during pregnancy in order to provide optimal protection to the infant, not preconception. If Tdap is administered at a preconception visit, it should be administered again during pregnancy between 27 to 36 weeks of gestation. Now 27, pregnant women should receive Tdap any time in pregnancy if it is indicated for wound care or during community pertussis outbreak. If there is an community outbreak you want to give, you can give it at any time during pregnancy. If Tdap is administered earlier in pregnancy, it should not be repeated at 27 to 36 week gestation. Only one dose is recommended in early pregnancy. Therefore, if you are given preconception, you have to repeat it. If you are given at any time during pregnancy, there's no point in repeating the dose. Now, many of us are concerned what the WHO would like to say. Now, in 2015 itself, WHO says vaccination of pregnant women likely to be the most cost-effective additional strategy for preventing disease in infants too young to be vaccinated and appears to be more effective and favorable than cocooning. National programs may consider the vaccination of pregnant women with one dose of Tdap in the second and third trimester and at least 15 days before the end of pregnancy. I think the Indian government should take note of this. The obstetricians and pediatricians to take note of it and make a move to at least vaccinate mothers with one dose of Tdap in states at least like Kerala. Cocooning may have an impact on disease prevention in some settings if high coverage can be achieved in a timely manner, but this is very difficult and cocooning is not something which is that effective. Now, we would like to know what the Advisory Committee of Immunization practices. The IAP says, it says Tdap during pregnancy, one dose vaccine to pregnant mothers and adolescents during each pregnancy, preferably 27 to 36 weeks, regardless of the number of years from prior TD or Tdap vaccination. Therefore, WHO, IAP, and the AAP are on the same page. Therefore, I think we pediatricians should be pushing for Tdap vaccination more than before. Forgive me to digress from the topic and put one slide which I couldn't resist from putting up in this presentation, though it's not part of the topic. This is regarding influenza vaccine. This is available, the vaccine is available, and I don't think any of you in any of the hospitals in which this flu vaccine is being given by obstetrician. It must be very, very rare. But look at the facts about it. Influenza vaccine has been recommended for pregnant women in USA since 1960. Currently, the influenza vaccine is now recommended for all pregnant women during each pregnancy. The vaccine can be administered in any trimester of pregnancy because this idea is not only to prevent flu in the mother and prevent stillbirth, abortions, and transplacental transfer of the transplacental infection of the child also. In 2012, the WHO Organization Strategic Advisory Group of Experts in Immunization recommended that countries considering initiation or expansion of seasonal influenza vaccination program give the highest priority to pregnant women. Pregnant women are the highest priority. The second is 6 months to 2 years. Now, wherever hospital you pediatricians are working, please do find out whether, please make a move to have flu vaccine also. They say that if you don't give it in antenatal period, give it when the mother is discharged also. Thank you for investing your time so long with me. I'm Dr. A. Padmanabhan signing off today. You can find other topics in pediatrics, which I put up similar videos in this link. Thank you and goodbye.